Hello, everyone, and welcome to this November 2025 edition of Eversight's webinar series. This is a complete approach to limbal stem cell deficiency, KLAL-Pro, and postoperative management strategies with Dr. Ed Holland and Dr. Nambi Nallasamy. Quick couple of housekeeping notes before we get started. This webinar, all of our webinars are recorded, available on demand on YouTube and our website. Also, please keep an eye on your inboxes for more webinars coming early next year, 2026. All participants are muted throughout the duration of the webinar, but please do ask questions. You can do so in the Q&A panel at the bottom of the Zoom application on your desktop or on your phone, and those questions will be answered by our speakers at the conclusion of the talk. You'll also be asked to participate in a very brief survey at the conclusion of the webinar. That'll come automatically when you sign out. Please do complete that. We invite your feedback. And now on to tonight's speakers. Dr. Nambi Nallasamy is a board-certified ophthalmologist and fellowship-trained cornea specialist. He specializes in the medical surgical management of corneal and ocular surface disease, including corneal transplantation, cataract and refractive surgery, secondary lens implantation and lens exchange, and limbal stem cell deficiency, including surgical interventions like amniotic membrane grafting, keratoprosthesis, and limbal stem cell transplant, which we shall hear about today. And of course, Dr. Ed Holland is the Director of Cornea Services at the Cincinnati Eye Institute and Professor of Ophthalmology at the University of Cincinnati. In this capacity, Dr. Holland has attracted a worldwide referral base for medical and surgical corneal problems, especially limbal stem cell transplantation. And his team at Cincinnati Eye Institute and the University of Cincinnati has the largest ocular surface transplant program in the world. He is the recipient of numerous awards, including the Castro Viejo Award, given by the Cornea Society, and has authored over 250 peer review articles. So very excited for this talk tonight, and with no further mumbo jumbo from me, I will turn the floor over to Dr. Nallasamy.
Great. Thank you so much, Mike. Appreciate the introduction and excited about the opportunity to speak with everybody about limbal stem cell deficiency and KLAL-Pro. As I indicate here on this slide, and as Mike was mentioning, Dr. Holland is a fantastic person to have joining us. I can't think of anybody better, and I'm excited to get started. So let's get into it. So let's see if our slides will advance for us here. All right, so just a few disclosures. As everybody who probably is tuning in is already aware, limbal stem cells reside in the basal epithelium of the limbus at the palisades of Voigt, and they produce cells that become the corneal epithelium. Importantly, they also inhibit corneal invasion of conjunctiva and vasculature, and there are a number of stem cell markers that we look at both in vitro and in vivo. They express typically p63 alpha and in particular certain isoforms of p63 alpha. That helps to maintain their stemness. So let's talk a little bit about how we divide up or classify limbal stem cell deficiency. We can divide it up into acquired and genetic causes. Acquired can span a really broad range, so chemical, thermal injury, radiation. One of our more popular injuries in our part of the country is fireworks injuries. So we get several of those every year. Infectious and inflammatory causes, especially Stevens-Johnson syndrome and pemphigoid are very common ones as well. Contact lens overwear, and then certainly prior surgeries, utilization of things like mitomycin and 5-fluorouracil, perhaps to excess can certainly do that. And even just really severe overuse of glaucoma medications, preserved glaucoma medications can result in limbal stem cell deficiency as well. Genetic causes are myriad, but include aniridia, one of the most common, xeroderma, and a few others. And when we're looking for limbal stem cell deficiency, there are a few classic things we think about. So corneal neovascularization and scarring, subepifibrosis, fibrovascular pannus. A lot of times we prefer to call this conjunctivalization because that usually is the actual source of that tissue that we're seeing overriding, especially in that, say, top right panel that you're seeing there. Um, but in addition to that, persistent or recurrent epidefects are common, and this whorl-like keratopathy, which you can kind of see highlighted down in the bottom right panel there with the fluorescein. Some more examples of what limbal stem cell deficiency looks like. And you can see kind of different stages of limbal stem cell deficiency. So in the early stages, perhaps just a little bit of late staining. And then as we go further and further along, more of that whirling that we talked about, more of that invasion of vessels, and possibly persistent epithelial defects as well. We can see changes in addition on confocal microscopy, which we'll talk about in just a moment. So when we're trying to diagnose limbal stem cell deficiency, one of the standards has always been impression cytology, although it is perhaps less commonly done these days. And I think a lot of folks tend to just make the diagnosis clinically. But impression cytology to detect conjunctival cells is certainly helpful. You can also do a scraping or biopsy to make that diagnosis. Cell biomarkers may be less commonly used in clinical practice, but certainly helpful in the lab. And then in vivo imaging, like confocal microscopy and intersegment OCT, can be helpful. So on confocal, there are a few different things that we can kind of look out for. One is absence of a normal corneal epithelium, or the presence of conjunctival goblet cells on the cornea. Excuse me. And another is epithelial thinning or the reduction of the subbasal nerve plexus and basal cell density. On anterior segment OCT, it's not always the most straightforward diagnosis to make, but there are a couple of characteristics that we can look for. So an absence or diminishing of the palisades and limbal crypts. We can also tend to see some changes in the epithelium, sometimes thinning and sometimes hyperreflectivity of that epithelium on anterior segment OCT. So when we think about therapies for limbal stem cell deficiency, and in particular surgical therapies for limbal stem cell deficiency, we really want to think about the stage of the limbal stem cell deficiency, as well as whether it's unilateral or bilateral. That's really going to help us make our decisions about what type of surgery to proceed with. So there are a few different staging tools that are out there for staging limbal stem cell deficiency. Most have something to do, allude to the area of normal epithelium or the area of epithelium that is involved, the degree of limbal involvement, and whether the central cornea is involved as well. Those are kind of the key pieces that we want to think about.
Say, Nambi, just a
Yeah,
comment here.
yeah,
To
please.
me, the most critical uh, thing about staging is whether the conjunctiva is involved, whether there's conjunctival scarring, loss of the fornices, symblepharon formation, and of course, ankyloblepharon formation. So the problem I have with this staging, I'll take a stage 3 with total limbal deficiency and normal conjunctiva
Mm,
as a better prognosis than a patient who has maybe 2/3 of corneal involvement, but extensive inferior symblepharon from a chemical injury. So to me, it's conjunctival involvement and whether there's active inflammation of the conjunctiva or not. So the worst prognosis cases are the Stevens-Johnson mucous membrane pemphigoid with a lot
yep.
of conj inflammation, conj scarring, and then it's the bad chemical injuries. And then you think about the best prognostics are the patients with the inherited disorders like aniridia. And then finally, the best diagnosis would be total limbal deficiency from contact lenses. Even though their total corneal can be involved, they can do great.
Mhm. Totally agree. That's super helpful. I appreciate your mentioning that. And Yeah, controlling that inflammation in those patients with thermochemical injuries really is a challenge. And I don't know how much we're going to allude to that during this particular discussion, but perhaps we can talk a little bit more about it as we go. Um, I know just to dig into that a little bit further, I know your preference is to, especially if it's unilateral limbal stem cell deficiency, to do a conjunctival limbal autograft to kind of bring some of that healthy conjunctiva over to an affected eye. Um, and it, do you ever think about immunosuppressing the patient before they get to that stage of doing the transplant to see if they're at a quieter point
Yeah,
before the
I,
transplant happens?
I think that's a very good point. If I take a patient who had a chemical injury 20 years ago versus a patient a chemical injury, 6 months ago. In fact, one of our, non-starters is we like to wait at least 12 months, sometimes longer, in the bad chemical injuries just because they have this chronic inflammatory reaction that takes a long time. And then often, obviously, pemphigoid, we're going to immunosuppress to get the conjunctiva quiet for a period of time. But even I think we've learned over the years that the Stevens-Johnson patients who have this chronic conjunctivitis that may have no limbal involvement, if you immunosuppress those patients and get that patient's conjunctiva quiet, you actually may prevent limbal deficiency. So we use a lot of mycophenolate in our Stevens-Johnson patients with chronic active conjunctivitis.
Yeah, absolutely. Same here. I think it makes such a big difference. It gives us so much better of a chance at success. So thank you for pointing that out. As we think about surgical treatment a little bit more, and again, we don't need to stick to the exact the exact stages that we listed on the previous slide. But there's a concept of using allogeneic limbal stem cell transplantation and autologous limbal stem cell transplantation, and that really has a lot to do with whether there's unilateral or very asymmetric limbal stem cell deficiency versus bilateral limbal stem cell deficiency. Um, so obviously we prefer to do an autologous transplant if at all possible, but there are some limitations um, that we can get into maybe as we go. Obviously, there is better long-term graft survival for an autologous graft because it is native tissue. We may be able to avoid some of the risks of lifelong systemic immunosuppression, but again, whether the autologous tissue alone is enough to properly reconstruct the limbal stem cell niche is certainly a question. So there are several different types of surgeries that we can consider for limbal stem cell transplantation. Unilateral options include conjunctival limbal autograft, as we alluded to, CLET and SLET, which I think both Dr. Holland and I, at least with regard to SLET, I think both Dr. Holland and I have maybe don't prefer SLET in this context. Maybe that's the polite way of putting it. I think that
I would say the most common unilateral disease is a unilateral chemical injury that has a lot of conjunctiva involvement as well as limbal involvement. And I've just I'm a bit biased because I get a lot of SLET failures, but I think they're KLAL or living related conjunctival limbal. I mean, for unilateral, certainly CLAU is my choice. Um, and then I do see SLET with partial disease in one eye and total disease in the other eye, and I think you're putting the partial disease eyes at risk. So, um,
Mhm.
yeah.
Yeah, and probably several different reasons why SLET maybe is not a great option in those situations. Maybe just not enough tissue, that you're not placing the tissue at a place at the limbus where there might actually be better survival of some of that tissue. But we can get into that as we go, perhaps.
And Nabi, the niche we talked about, right? The normal anatomy of that limbal niche.
Yeah. Hmm.
SLET chops the cells up. Whether we're doing keratolimbal allograft, CLAU, or living related CLAL, we're preserving that anatomy, that limbal niche that we think is quite important. And all those procedures give many, many more stem cells than we get with SLET.
Hmm. Yeah, great. For bilateral limbal stem cell transplant, we have the living-related conjunctival limbal allograft, one of our most favored procedures, keratolimbal allograft, and then the Cincinnati procedure, which is a combined living-related conjunctival limbal allograft and a keratolimbal allograft. So just to very quickly take you through some examples of what these look like, some diagrams of what these look like. For a CLAU or CLAL, we're removing that conjunctivalization from the affected cornea, and then we're suturing in these. We're obtaining a tissue from the healthy donor eye, whether that's the patient's other eye or the donor's eye. And then we're placing this tissue usually at the 12 and 6 o'clock positions, and suturing those in place. For SLET, we talked about that a little bit already. We take a small biopsy. We again remove the conjunctivalization from the affected eye. Some people place an amniotic membrane, some don't. When I used to do some SLET, I actually preferred not to have a basement membrane of amniotic membrane. I actually preferred to have the tissue directly on the ocular surface. I found that there was slightly better adhesion that way. But then we take these pieces of tissue that are divided up, and we place them in the mid-periphery of the cornea, and then perhaps may place either a contact lens or an amniotic membrane graft over the top of that. Keratolimbal allograft is something that we typically use in patients who have bilateral limbal stem cell deficiency. So again, we remove the conjunctivalization from the recipient eye, and then we take the donor tissue. Usually we're taking tissue from both eyes of the donor. And then we're creating these lenticules, usually 3 lenticules, to cover the entirety of the limbus of the recipient eye. And in conjunction with Eversight, our team has created a kind of eye bank prepared keratolimbal allograft tissue, which we call KLAL-Pro. So it is transplant ready, and we'll talk about that in just a moment. So we're going to dive a little bit further into where we can use and how we use keratolimbal allograft tissue. As we mentioned before, we can use it both in the context of a total bilateral limbal stem cell deficiency, or we can use it in conjunction with a living-related conjunctival limbal allograft or a conjunctival limbal autograft as well, if we feel that a patient needs additional limbal stem cells in order to succeed. In my experience, I find that our patients with thermochemical injuries are the ones who really need that extra limbal stem cell tissue, so I tend to do what's called a modified Cincinnati procedure, so conjunctival limbal autograft plus keratolimbal allograft. Dr. Holland, is that how you feel about it too?
Yeah.
Is that
Yeah, I think it's important, when you have that extensive disease and a lot of the bad unilateral diseases are terrible chemical injuries. And we were just doing living related, we'd have that exposed 3 and 9 area and we'd see conjunctivalization there. So adding the KLAL segments to complete that 360 rim is made a big difference. So we kind of, whether we're doing a CLAU only or with the KLAL on a unilateral, it's really the degree of conjunctival involvement. And we make that same decision if we have a good living donor and HLA matched, we want to use that over KLAL primarily because of the reduced risk of rejection. But again, a lot of the bilaterals, the Stevens-Johnson patients, the pemphigoid patients, the bad chemical injury patients, they have a lot of conjunctival disease. And so that's how we, came up with the Cincinnati procedure to deal with that. So we do as many Cincinnati procedures as anything.
Mm-hmm. Great. So this is that modified Cincinnati procedure that we were talking about that utilizes the KLAL tissue as well. And that takes us to this KLAL-Pro tissue. And what I really think is exciting about this is not so much that it's designed to surpass or improve upon standard keratolimbal allograft tissue that's prepared by the surgeon. It's really just to make the surgery itself more accessible. So I may have used this this analogy before, but I hope that this does for keratolimbal allograft what prepared and preloaded DMEC did for DMEC, just to decrease surgeon time in the operating room, to make it easier for the surgeon to get started with the surgery if they haven't been doing it before, and just feel that it is that there is support for getting the surgery done. So KLAL-Pro is a limbal stem cell enriched graft tissue that is prepared at the eye bank preoperatively. And so this was we had a protocol that we developed. So Dr. Ankar Sawant and myself developed this protocol with Eversight Eye Bank to essentially standardize the process so that eye banks could prepare this tissue for surgeons. And so they start by identifying this palisades enriched region of the cornea. We use a guarded depth vacuum tree find so that we can obtain the desired depth. And for us so far, that's been primarily around 200 to 300 microns for our dissection. So we'll use that vacuum tree find to get to that depth, 360 degrees, and then we'll use a blade to start dissecting outward from that trephination toward the sclera, and then we dissect out that the anterior limbus portion of the tissue. What's nice about it is that we have some options for customization. So typically, in anterior-posterior extent, it's somewhere between 2 and 3 millimeters wide, but you can choose if you'd like more or less. And you can also choose the arc length. And I'll show a case later where it was actually helpful to have a very long arc length as opposed to our usual kind of 1/3 of the 1/3 of the limbus arc length. And so that can be kind of helpful as well. And if the surgeon has a particular preference with regard to depth, that can be accommodated. One of the things I do really like is that we also get a post-processing depth confirmation in the OCT. So on the data sheet that you get from the eye bank from Eversight, it will actually show you this OCT so that you can confirm that it was dissected the way that you would have liked. And visibility of the palisades is ensured. So it's confirmed both before and after the dissection, just to make sure that the tissue continues to look good before it's sent out to you. And then the tissue is sent just in typical cold storage medium to you, the surgeon, and arrives ready to use in the operating room. Obviously, one of the most important pieces of this is using it with the Cincinnati protocol, which Dr. Holland is going to talk to us about in just a moment. So perhaps we can switch slides over. I will stop sharing.
Thank you. I'm very excited to, the step that is really time consuming is that dissection in the OR of the keratolimbal tissue. And some eyes, it's pretty easy, and other eyes, it's much more complicated. So that is very exciting. Let me just get my slides up here. So, just historically, I think ocular surface disease, severe ocular surface disease with limbal deficiency has been a huge unmet need for our patients. And I think as our specialty, we've just kind of ignored these patients, failing to properly diagnose and treat and refer for appropriate treatments. The number one surgical procedure done for patients with total limbal deficiency still to this day is penetrating keratoplasty. A penetrating keratoplasty in a patient with total limbal deficiency has a 0% success rate, yet it's continued to be the procedure that is most commonly performed. And there are a lot of misconceptions I see out there that I see patients with repeated PKs. If a patient has a total limbal deficiency and the PK failed, and I don't know why people keep doing them. We see patients who've had numerous superficial keratectomies and AMT. And again, that has a role in the management of these patients, but it's not going to treat the underlying problem. And then, I'm very excited about this next generation of surgeons like Dr. Nallasamy here and others who are really getting excited about properly managing these patients, because for too long, a misconception has been that ocular surface transplants have a poor success rate, systemic immunosuppression has a high mortality rate, and then you can't use the fellow eye to obtain tissue because those patients have a high risk of developing limbal deficiency. Those are all not true. We actually have very good success rates, somewhere between 70 and 85%, depending on the preoperative diagnosis. We'll show some data on our 20-year success rate on immunosuppression. I've been doing this almost 40 years, and we haven't had a single death in any of our patients receiving systemic immunosuppression. And we haven't had a single patient lose vision from a stem cell harvesting from a living related donor or fellow eye donor. So those are all true. So if stem cell transplants are safe and effective, why are so few performed? We're not even touching 1% of the patients. The surgery is different. I don't think it's super challenging to most cornea people. Unfortunately, the reimbursement's not very good. Surgeons really don't want to operate on normal eyes, so they don't like doing the living-related procedure, and they certainly don't like to do a conjunctival limbal allograft because of this fear that's propagated. Every single SLET paper published starts in the first paragraph. The high risk to the donor eye in an autograft or an allograft, and then they go on to say why they have SLET. And again, and we've published our review of our donor eyes, and that's simply not true. These patients do take a considerable amount of time, and it's long office visits and many phone calls. I'll talk about the team approach and how you get around this. And then finally, I think the challenging medical management, as cornea specialists, we're not really trained to do this, but we certainly can learn. We all went to medical school. We're all doctors and we can do this. And, I saw a patient one day that had 14 failed penetrating keratoplasties in a Stevens Johnson patient. And it just got me motivated to try to, publish why there's this resistance to treating patients. So if you're interested, this came out 2 years ago in an editorial we wrote in the journal Cornea that kind of summarizes, the where these patients are and the obstacles for these patients to get properly treated. But I think we figured it out. And I certainly, these surgical procedures that Nambi talked about, a lot of them were actually proposed in the early 90s, and a lot of cornea people used the procedures. But we weren't all in on immunosuppression. We didn't have that confidence, and I didn't either. And a lot of our patients, well, majority of them failed due to rejection. We then, as a specialty, kind of wrote this off as well. These procedures don't work. And it would be like doing a kidney transplant and immunosuppression a patient for 3 or 4 months and then stopping immunosuppression and wonder why the kidney failed. So the Cincinnati protocol is really a management style that's basically been adopted from what is done in organ transplantation. The renal docs are the ones that really start us down this pathway. They really have taught us how to properly immunosuppress, and our protocol basically follows what is done by renal. Now, you have to start with a corneal surgeon who wants to take care of these patients and will be the quarterback. You need glaucoma, retina, and an oculoplastic specialist. We think you need to partner with nephrology. I don't think we see people that try to work with internists, rheumatologists, oncologists. The specialty of systemic immunosuppression for transplantation is very, very different than what an oncologist would do. And it's a unique specialty. And I choose nephrology as our partners because they're really the leaders, and they have all the breakthroughs, and we follow their treatment paradigm. And we also follow the fact that if you're doing a lot of these, the corneal surgeon doesn't have the time to micromanage all these patients need labs throughout their treatment for years. They need, preoperative testing, postoperative labs. They have side effects of the medication. And a cornea surgeon can't do it. You need to follow what is done in organ transplantation, and that is a transplant coordinator. So, we talk about the importance of a coordinated team. Like I said, corneal surgeon is the quarterback. Embrace systemic immunosuppression 100% like renal does. We partner in our team. The head of renal at University of Cincinnati we work with him every week on patient issues, mostly through emails. They rarely have to see our patients. We need guidance on HLA tissue typing and who's the best donor. We need guidance on if there's a medication complication, how do we switch out to that? And then come up with funding for a transplant coordinator. And unfortunately, in in cornea, we don't have codes to pay for that like they do in organ transplantation. So this is where there's a financial obstacle that we have to overcome. And each program we work with who wants to adopt the Cincinnati protocol, our foundation actually provides funds to get centers started, and most of that funding is going to hire to a transplant coordinator. So every team is different. What Nambi is doing at University of Michigan is different what I do, but I have my partners at Cincinnati Eye Institute. I use our renal transplant team. St. Elizabeth is the hospital I work at. They help fund my transplant coordinator. And then we had so many referrals in kids. About 10 years ago, we started doing ocular surface transplants in children. The difference, I would say, in kids is that in adults, we do a lot of the management of the medications, and probably 95% of the time don't really need to bother nephrology with the issues, especially with young, healthy patients. But in children, 100% of their management is by the nephrology team in Cincinnati Children's, and we're blessed with an outstanding renal team there. So a little bit about how we approach the patients, and Ami talked about this. Stage management is best. So years ago, we tried to combine stem cell transplant with a tube shunt or stem cell transplant with a PK. The less you do, the better. So first and foremost, when you see these patients, we want to get their glaucoma under control. The other thing I found when I was a younger surgeon really trying to fix their surface and not as aggressive about their glaucoma as I'd get a beautiful stem cell transplant, a beautiful penetrating keratoplasty, and a white optic nerve. So very aggressive about surgical management. And I have my glaucoma partners, we have a kind of a paradigm, and we typically maximum 2 topical meds, and we're going to go to a surgical solution. And then evaluate the eyelids. If the patient has incomplete closure or entropion, that's going to destroy your ocular surface. So lid abnormalities are second. And then, as Nambi said, inflammation, that patient with Stevens-Johnson syndrome and active inflammation, we don't want to do a stem cell transplant in that patient. We want to control their inflammation. So if we get the pressure controlled, the lid anatomy fixed, the inflammation controlled, then we can go on to pick the stem cell transplant. And we rarely would do primary K-pros. We almost never do that. We sometimes do K-pros in patients who've had a stem cell transplant that rejected their penetrating keratoplasty, but rarely do a primary K-pro. And then finally, if we get a successful stem cell transplant, we can go on to a PK or a DALC to get the patient's vision back. So a little bit about the evolution. So you look back in the 80s, late 80s and 90s, and we were using prednisone alone or cyclosporin and prednisone, and these were all failing. It really wasn't until the 2000s where we really, for me, I went to the University of Cincinnati and I went to renal. I said, teach me exactly what you do. I have these cases that look great, but I have too many cases rejecting. And this triple drug therapy was really what really changed the game. And I'll talk a few of the breakthroughs. And what I'm showing tonight, because we don't have time for me to go in detail, all this is published. It's either in our cornea textbook or we published a lot of this work in the journal Cornea. All this is out there. But we individualize immunosuppression. If we have a patient who we have a living donor that has a great HLA match, and we'll talk about the PRA test in a minute, but say a low PRA, that's a great prognostic patient. If we have a patient that we have to use a deceased donor for KLAL that we get no matching and their PRA is high, that's the worst prognosis. And so we titrate the immunosuppression based on the patient. And this is kind of our protocol of how when we taper the meds, and we'll talk about that in a minute. But a little bit about the screening. So if we're using a living donor, and that's our preference if we can, because the rejection rate's lower than keratolimbal allograft. But the most common procedure we do is actually the Cincinnati procedure. We're doing both, but ABO typing, HLA typing, cross-matching, panel reactive antibody, and then all the virology screening that we would normally do. And then the recipient, the typical test, but I want to focus in on panel reactive antibody, and that's a test that screens for a known kind of HLA antigens, and there's percent that you get from 0 to 100%. 0 is the best, 100% is the worst. Renal and organ transplant has been doing this for years. the lower the PRA, the better the prognosis. So we started doing, and what they showed in renal is if a PRA is over 50%, that has a poor graft survival. And so we we do this in all our patients now, and Albert Chung in our group has published a series of patients where the PRA was below 80 and above 80, and you can see the survival rate is very, very different in those patients that have the lower PRA. So yeah, again, this is an example of taking what we've learned from renal and bringing it to ophthalmology as we should. The protocol of using mycophenolate and tacrolimus and then corticosteroids is what's kind of standard in organ transplantation. But the University of Cincinnati several years ago proposed steroid sparing management. And again, I look back at how much prednisone I was using, 80 milligrams for a couple months and 60 and 40. And what UC showed us is that most of the side effects the patients have are due to the prednisone. And so they've taught us to use lower doses, and we almost get all the patients off prednisone by 3 months. And so, I used to think I was out 9 months in a year on oral prednisone, and the weight gain and the mood swings and the blood sugar changes and the hypertension. That wasn't mycophenolate, that wasn't tacrolimus, that was prednisone. And so our patients are happy and our results are the same. So steroid sparing is a UC thing. And this kind of talks you through our initial typical dosing. We do get tacrolimus levels, and we try to titrate those levels between 8 and 10 the first few months. And then after 6 months, if everything's going well, we drop it down to 5 to 8. And then we look at discontinuing that between year 2 and 3. We used to think about stopping mycophenolate at year 5, but we've had some late rejections. So depending on the diagnosis, say Stevens-Johnson, we may keep patients on a lot longer. If you get mycophenolate down to 500 milligrams twice a day, they can do very, very well with almost no side effects. So we're tending to use a little longer mycophenolate than we did. We have induction therapy, again, with monoclonal antibodies. This is, again, from renal. We won't go into detail. The postoperative lab monitoring, this is where you really need someone besides the corneal surgeon, because we follow their lab tests when they're stable at least 4 times a year. We follow the tacro level, several times in the first 6 months till we get a good level. They need their blood pressure followed, they need their blood sugar followed and things. So a corneal surgeon can't do it. If you're doing a few cases a year, maybe, but if you're doing a significant volume, you need a nurse's help. We again, what renal does is prevention of CMV. They get vanciclovir and then they get sulfa trimethoprim for pneumocystis prophylaxis, and we taper that. So we did, get this question when patients would come to us. I think your surgery sounds better than maybe a K-Pro, or your surgery sounds better than having another transplant, which I've rejected multiple, but I don't want to die. That's what patients would say to us. And we said, there's another option. You can have our surgery, you can have systemic immunosuppression, you get your vision back, and you don't have to die. So we looked at a 20-year experience, 270 patients, 389 eyes. We've had no deaths. We still have no deaths. We've had minimal side effects. We've had one secondary tumor, and that was a melanoma that was in a KLAL donor that died of a melanoma, and the immunosuppression allowed that tumor to grow off the KLA segment. EBAA has now changed the whole medical standards not to allow that to be a donor. We've had a couple MIs and a pulmonary embolus, but in over 1,200 cases now, no deaths. And what I say is, we are transplant surgeons, right? And these patients need the best outcomes, and the best outcomes is to do what other transplant surgeons do. And really, cornea is the only specialty that doesn't really embrace systemic immunosuppression. And I see K-Pros done for patients who've had, say a transplant done for keratoconus or herpes, and they have multiple rejected transplants, and they go to a K-Pro. I would much, even in that patient, go to systemic immunosuppression. And those patients do very, very well. And a lot of these patients are young and healthy, will do well with systemic immunosuppression. Just a little bit about everybody doesn't need to be immunosuppressed. So we started looking at elderly patients over the age of 70 that had some medical issues, and we were really a little bit worried about, um, you know, totally immunosuppressing those. So Albert Chung and folks in our group looked at low immunosuppression or no immunosuppression. So low would be typically CellCept alone in these groups of 14 patients. And again, because the older the patient, the less, functional their immune system is. So you can get away in this group of patients with low dose or no immunosuppression. We had 57% with a stable ocular surface, improved visual acuity at about 86%. So we had some partial failures, but overall, we improved their quality of life without really risking, the patient taking immunosuppression. So something to think about in those patients. We've had some changes to the protocol. Clara Chan and her group in Toronto has taught us that, even when we're doing KLAL, we can't really do HLA typing like they can in Canada because most of their KLAL donors are solid organ donors, and that's not what we get. But we can do ABO typing, and ABO typing has been a big addition, and so we try to do ABO typing now. And then they've added IVIG as a, kind of a management. It reduces T cell function, B cell function, and useful in patients who have acute refractory rejection. And so that's kind of our medical approach. And I'll stop here and turn it back over to Nambi.
Yeah, Dr. Holland, I was wondering if I could ask you a little bit about something
Sure.
on your previous slide. So you had mentioned, actually, do you mind just pulling up the slide before your last slide?
Oh, sure. Sorry about that.
No, you're
This slide here.
I think before that.
Okay. Let's see. Not sure why it's not going back. There we go.
And the next one, actually.
There we go.
Yeah. So you were talking about ABO matching and how that's certainly easier to do with our deceased donors. Are you typically doing a true ABO matching, or are you doing just O negative donors these days?
So we try to do ABO matching or O negative. That's a good point. If we can't do ABO, then that's a good point. And Dr. Chan has data showing with that, and their system and trial, they actually get HLA matching in some of those KLA donors, which we'd love. But
Yeah.
so these protocols continue to evolve and change. What we do now, we certainly didn't do 10 years ago. And with each evolution of these protocols, we're getting better results.
Mhm. One more quick question for you. When you're looking at the results of your HLA typing, say for a living-related conjunctival limbal allograft,
Yes.
and you're kind of reviewing what the donors, the quality of their matches are you doing that with the help of your nephrologist, or do you have an HLA lab that helps you with that? How do you go about that?
So years ago, the HLA form I used to get was pretty simple, and I could figure out, if the donor had a normal ophthalmic exam, that's the one I wanted to pick. It's so complicated. So the HLA lab is within the University of Cincinnati, and that's one thing we do rely on. And renal is because a couple other issues. Let's say a recipient has 5 siblings. Well, the testing of the siblings are not covered by insurance, about $1,200 per sibling. So one of the things we do is we start testing. We don't test all 5, we test one, and then we run it by renal and say, how good is this? And they often will say, how concerned are you about rejection? And we'll say, well, it's a kind of a low risk patient, and they'll say this match is pretty good. Why don't you go with it? Because a lot of people cannot afford to get everybody tested, who's a potential donor. So that's one of the probably main ways we use our nephrology colleagues is they really help us in which donor to pick.
That's great. And then maybe this is getting into more of the minutia, but it is an issue that I run into myself sometimes. Sometimes our patients have donors who were coming from other states or even other countries. I had one where his donor was in Ukraine, and we were
Yeah.
trying to figure out, how can we get the testing done in an appropriate way. Do you have any tips for folks on how
So
to do?
if it's a U.S. patient, all the HLA testing can be done. We send them a kit,
Mhm.
and then the patients will send the blood back to our HLA testing center at the University of Cincinnati. So
Mm,
it's worked really well for anywhere in the U.S. And so that's been a problem. Overseas, it's been a little bit of an issue in getting that done, but certainly within the U.S., it's not been a problem.
that's great. Thanks. Um,
All right, I'll give the show back to you.
Sure, maybe we can finish up with just a few examples of some cases using KLAL-Pro, um, and then we can finish up. Let me see if I can share here again. There we go. So we were talking about this post-processing depth confirmation, which is really great to have. And so we'll run through just a few quick cases. These are 5 consecutive cases of patients who had received KLAL-Pro tissue. You may have seen some of these in other in other settings. This is a patient who had a thermal burn with coffee, and thankfully his other eye escaped injury, but this eye was pretty severely affected, and he had hand motion vision. We decided to do a conjunctival limbal autograft plus a keratolimbal allograft. And that kind of goes back to our conversation earlier about wanting to have some additional limbal stem cell tissue for a patient with such severe disease, a severe unilateral disease. And so we proceeded with this modified Cincinnati procedure. This is just a couple of images from intra-op here. You can see superiorly and inferiorly, we have the conjunctival limbal autograft tissue, and then we have a couple of KLAL-Pro pieces at 3 and 9. And we can see at post-op week 1, we were about 70% epithelialized with an improvement in the surface, but you can still see some of the haze from the initial injury. But as we proceeded on through his post-op course, he continued to improve. His vision improved to 2100 by post-op month 1. His photophobia and his epiphora had resolved. And this was kind of an unusual case where we were able to use very limited immunosuppression. This was actually an incarcerated patient, and so utilization of the full complement of systemic immunosuppression was not as feasible for us in this context. And so we hoped just to provide some protection for those keratolimbal allograft pieces, but we're leaning heavily on the conjunctival limbal autograft pieces.
Nabi, a great case. So first of all, in the slide on the left, you can see where the scarred conj kind of comes up to the keratolimbal allograft tissue and stops. It's it blocks that scar. I without that piece in there, that tissue would have grown onto the cornea. So this is a perfect example of how that manages that potential recurrent conjunctival scarring. And like you point out, this was a special situation. You had the autograft tissue. So I think what happens is early on, you get cells from both the keratolimbal allograft and the autograft. And over time, his cells will all be from his autograft eventually, and that's fine. So an example how, you have to make some adjustments depending on the patient.
Thankfully, he continued to do well even at post-op month 6. The vision continued to improve, and he's he's doing well at this point, which is great. So moving on to a second case, this is a patient who had a Roman candle injury, which unfortunately is very common around here for whatever reason. People shooting lots of Roman candles at each other. This is a patient that we tried a slightly different technique where we used early conjunctival grafting because we had recognized this limbal stem cell deficiency that appeared to be complete at post-op week 1, at post-injury week 1, which is when he presented to us. So we used this early conjunctival grafting, which is a technique that had been previously suggested. Really, the idea was just to protect the cornea from decompensation, providing a quick epithelial barrier against melt, and maybe in theory reducing the stimulus for conjunctivalization, and hopefully preserving those fornices, because what we do see sometimes is that we have a dragging of the conjunctiva from those fornices that then perhaps may be contributing to shortening of those fornices, which then requires multiple fornix reconstructions in order to reverse that. And so by the time we got to post-op month 11, we had done a fornix reconstruction for him, but it was really pretty limited in comparison to the usual situation in cases like these. And the the conjunctival tissue did quite nicely, provided this very thin, relatively clear barrier against melt, and even without any further intervention, the patient was seeing 2200. But we felt that he was at that point ready for stem cell transplantation. The nice thing about putting your own conjunctiva on the cornea is that you get a really easy dissection of that conjunctiva off of the cornea. And so then we were able to add the conjunctival limbal autograft tissue from the other eye and this KLAL-Pro tissue. So on the right panel there, on the right side, you see that nice piece of KLAL-Pro tissue, which fits very nicely. Obviously can be trimmed to size, but this was very straightforward for us to add. And so at post-op month 1, had fully epithelialized, vision was improving, pinholing already to 20/25. Eventually did need cataract surgery because of the prednisone inducing a cataract, but he did quite well with that. And at post-op month 7 had best spectacle corrected visual acuity of 20/50 after this long course. This third case is just kind of a more standard keratolimbal allograft in a patient with stem cell deficiency related to vitamin A deficiency. In this case, again, pretty substantial conjunctivalization dissected off of the cornea, and then we see our standard 3 segments of keratolimbal allograft tissue. In this case, these were KLAL-Pro segments, which made things relatively straightforward again to add the tissue. And then we can see post-op month 6, he's doing quite well, maintaining a good epithelial surface, but he does have this prior corneal scar from an ulcer that happened in the context of his persistent epithelial defects due to the limbal stem cell deficiency. So we intend to address that with a penetrating keratoplasty in the not too distant future. And this actually raises a
And Nambi, we get these years ago. We used to get this question: why do you use 2 corneas to get 3 pieces? It's 2 corneas, and is that excessive use of tissue? My first answer is most of those patients have had 6 or 7 transplants, and they've all failed, and no one said that was excessive use of tissue. But when we try to use one donor, if you make those pieces touch, the donor's tissue is too far on the cornea, and it's very disruptive on the quality of vision, and when you do a keratoplasty, it's difficult. So the donor and a half. So first of all, we can cover a larger area. You get a lot more stem cells, and the new limbus is now posterior. So the outcomes are so superior. And if we use one donor and recessed it back like there and left gap areas, the conjunctiva would grow in. So with keratolimbal allograft, you have to have all pieces touching. You can't leave gap areas. And the 3 sections, gives us such superior results. And then the 4th piece, sometimes if we're managing inferior, say, severe symblepharon, we'll take the 4th piece and put it in a layer back, to help reconstruct the ocular surface and reduce the amount of conjunctival scarring.
Yeah, great points. I'm actually curious about your thoughts on this. So we're planning to proceed with his other eye with the keratolimbal allograft as well, but curious how you think about timing of penetrating keratoplasty after ocular surface stem cell transplant.
Yeah, if we follow the epithelium, the eye's quiet, we got total epithelialization. This epithelium looks good. Our typical timing is about 3 months to go to a PK or a DELC.
Great. And if you're doing bilateral keratolimbal allografts, is your preference to do both eyes, both of the keratolimbal allografts first, or would you proceed with the penetrating keratoplasty in the first eye?
Typically, we proceed with the keratoplasty because the patient's so anxious to get their vision back,
To
and
see
they don't
better,
want to sit and wait for both. So we will do a full reconstruction, get vision in the first eye, and then move to the second eye.
Fair enough. This is a excuse me, a fourth case. This was an iatrogenic chemical injury. Patient had gone to urgent care, was given some eye drops for some foreign body sensation. Turned out the eye drops were severely alkaline, and he presented to the local ED with a pH of 9. That was not RID, and so he had a long course before he ended up coming to us and had even an inferior fornix reconstruction um, prior to coming to see us at all. And then we did an additional fornix reconstruction to get to this stage that you see in the bottom right panel there. And it's not as obvious on this photo, but essentially the infranasal half of the cornea has conjunctivalization. It's just not terribly straightforward to see with this particular view. So we did a slightly unusual technique where we utilized one conjunctival limbal autograft piece of tissue, and then we used, because we had the ability to kind of specify how we wanted this dissected, we took a very long piece of KLAL-Pro tissue, a single segment, and actually wrapped it behind the conjunctival limbal autograft tissue to create, at least in theory, a little extra barrier for that for the conjunctivalization. And at least turns out that this has worked reasonably well for this patient. You can see on the right, on the left there, his initial appearance, and then on the right, the appearance after the surgery with that surrounding KLAL-Pro tissue. And you can see that the eye is much quieter, that significant, those beefy vessels that we saw infranasally without actually touching the conj there have actually regressed quite nicely.
Amazing case.
And then this last one is just a paint thinner injury, but I think it goes to what we were talking about earlier with regard to SLET. That SLET, even though it may give you some reasonable results at first in patients with really significant limbal stem cell deficiency, it really may not be enough for those patients, and it's worth thinking about whether there's an alternative procedure that might be more effective. So this patient had had a SLET 5 years prior with some initial improvement, but had a pretty severe return of conjunctivalization, photophobia, and epiphora, and his vision declined to 2200. So we ended up doing, because he had already had the SLET, we decided to be a little bit more conservative about it. I'd be curious, Dr. Holland, your thoughts on whether it's worthwhile to try using just one piece of conjunctival limbal autograft tissue, or whether you would have gone with two in the context of the prior SLET.
Did he have one area harvested for SLET?
Just one,
Yeah.
yeah. So we
I'd
probably
probably
could
you
have gotten
I would only do one piece. We try to limit to about 40% of the limbus. That's kind of our standard. So if he had, two sections biopsied, I wouldn't have used the fellow eye, but I would have done just what you did. And he had at least one area that you could go after that was not surgically traumatized. So
Yeah. And he did pretty well so far. His vision has improved pretty substantially, and he's had a near elimination of that photophobia and epiphora that he was experiencing. So um, those are some cases. Happy to talk about those more if anybody has questions as we're finishing up here. But just to kind of recap, some of the benefits of this KLAL-Pro tissue, at least the way that we see it, is this decrease in operative time, that dissection of the keratolimbal allograft tissue. If that's something that you can move out of the operating room, that certainly makes these surgeries quite a bit more reproducible in terms of timing, and certainly a bit more straightforward. The customizability of the tissue is nice with regard to arc length, anterior-posterior extent, and even the donor characteristics. So as of right now, I typically will request from Eversight that we get O-negative donors, or if we have the bandwidth, then we go for actual ABO matching, but O-negative obviously works quite nicely. We know that the requested dissection depth is achieved by the time that we get to the operating room, which is great. And some of the things that we're thinking about right now are can we improve the storage media that we use so that we can kind of maintain the stemness of tissue of the graft tissue through the time of the transplantation. We've had a few studies kind of looking at this. Dr. Holland, I don't know if you want to touch on this a little bit.
Yeah,
Just
there
from
was some questions whether if you had prolonged preservation time, will this terribly affect the KLAL outcomes? And again, our storage times, just the way tissue is going, it became longer, and we recently published this study showing that prolonged storage time over what we used to ask for is 3 days does not change our outcomes as long as we have the same kind of evaluation of a good epithelial layer, a healthy looking limbus as the donor.
Yeah, and when we looked at kind of a similar scenario in vitro, even though we saw that there was a decrease in p63 alpha expression in these stem cell tissue harvest, the colony forming efficiency of those tissues was actually still quite good. And so it kind of supports this idea that the tissues are still viable even after preservation for that time frame that you're referring to. The one thing that we did see, though, was perhaps a trend toward younger donors being having greater colony forming efficiency, and then secondly, that a reduced death to preservation time might be helpful as well. So things that we can consider as we continue this discussion with the iBank. Um, Certainly, lots of other things to think about as we go forward as to how we can improve keratolimbal allograft outcomes. Modifying that storage medium, I think, is probably a big one. So can we add growth factors or niche supportive signals, antioxidants or metabolic substrates? I think all of those things will be things that we explore in the not too distant future. I think the question of organ culture is also very interesting. Um, we do know that it preserves those LSC markers like p63 alpha through 28 to 30 days in kind of warm storage in organ culture medium. Dr. Allen, I don't know if you have any thoughts about whether that's relevant for the
Yeah,
US.
it's interesting because University of Minnesota actually invented organ culture corneal preservation when I was a resident there in 34 degrees, and we used to store corneas up to a month.
Hmm.
I don't know what happens. One of the downsides of that storage time was that we'd have poor central epithelium on the donor. I don't
Mhm.
know what happens to limbal stem cells in prolonged storage, so that would be an interesting thing to look at.
Great. And we touched on some of these other things, so I think maybe we can wrap up there in the interest of time. Happy to take any questions, but thank you everybody for your attention. Appreciate it.
Thank you both so much. I really enjoyed this talk. It's really interesting. This is kind of an area, as we've established some other transplant types, endothelial keratoplasty, quite solidified. I think this is an area where there's still a lot of room for improvement and research, and I'm glad that you all are doing it. And we do have a couple of questions in the chat here, and the first one is and I guess we'll direct this to Dr. Holland first and go back and forth as the questions come in. Is there a role for topical tacrolimus in stem cell allograft patients?
So all the patients besides systemic immunosuppression are on prolonged topical steroids. They're on steroids forever. We like to add topical cyclosporin or lifitegrast or sometimes tacro. So I think all those are kind of additive and can play a role. But the critical thing is systemic immunosuppression. I will say that difluprednate as your steroid is significantly better than any other steroid. Obviously, IOP issues sometimes get us to change off that steroid, but we always initiate steroid management with difluprednate. I think by far that's the most effective topical steroids in these patients.
Any thoughts to add, Dr. Nallasamy, on that question?
No, I agree. I think certainly some of the topicals are great adjuncts, but the systemic immunosuppression is really the key here.
So the question number 2, I'll throw this one to Dr. Nallasamy. How do you work with your optometry colleagues regarding patients needing scleral lens fitting to avoid stress on those allograft segments?
Yeah, that's a great question. So we are very lucky to have some excellent optometrists who do our scleral lens fitting for patients with ocular surface disease. So they are working with us on patients who have bad symblepharon that we are doing fornix reconstructions on and the like. And so they're accustomed to dealing with very challenging patients. I think the key is really just communication with your optometry colleague on what it is that you need and what you've done for the patient, what kind of surgery they've had, and what to avoid. I think that I think our optometry colleagues are more than willing to learn with us and work with us on figuring out how best to treat these patients. So just really engaging them and getting them involved in the process.
Yeah, I would say, we use them both pre-op and post-op. We have patients who have partial deficiency in irregular epithelium that may be slowly progressing. We can fit them with a scleral lens and get functional vision and put off an ocular surface stem cell transplant. So that's especially important, say, younger patients, especially young anorectics, who we'd like to see them older before we immunosuppression. And then post-op scleral lenses have been an absolute, wonderful way to not only manage irregular stigmatism, because we may have improved their surface and we don't want to do a keratoplasty and they have some irregularity, scarring of their cornea. You can get tremendous visual outcomes with that. And it helps manage the severe dry eye that these patients almost always have. And so scleral lenses are a big part of our management paradigm.
Well, thank you both. I think that's it. That's just those 2 questions we had in the chat. So we'll go ahead and wrap up for tonight. Thanks to everyone for logging in. Special thanks to both our speakers for sharing your expertise with us. For all the participants, please do complete the brief survey that'll be populated as you log out. And keep an eye out for the next webinar 2026. Any final thoughts from you guys?
No, I just, as I said at the outset, I think limbal deficiency is the biggest unmet need in cornea, and I really am excited to see more and more people interested. Eversight being interested in making a better, a more efficient way to deliver keratolimbal allograft tissue is going to be a big advantage. So, yeah, I'm excited for the future for these patients.
Me too. Thank you.
Yeah, thanks.
All right. Thank you both. And everybody, have a good evening and see you guys in Cincinnati.
Thank you.
Bye-bye.